Hello, I'm Dr. John Kruse, and today I'm going to be talking about medications for Alzheimer's disease. So this is one of the more general mental health focused talks, not one specifically on ADHD. I'll be talking for about 20-25 minutes. This video may well be longer than that because there will be a question and answer period, and that may well be on ADHD questions as well as what I'm talking about today. And as usual, I'm going to start with the take-home message first and then launch into the topic. So the take-home message is that Alzheimer's disease is incredibly important to be aware of. It is the 7th leading cause of death in America, and 1 out of 5 women and 1 out of 10 men will deal with Alzheimer's during their life. That's a fairly high rate. There have been 3 waves of medications over the last 30 years to treat Alzheimer's disease. And the first 2 groups of medications, I would say, are compensatory. So they are not designed to change the disease process at all. So the first was anticholinergic drugs like donepezil, tacrine, rivastigmine, galantamine. Those boosted acetylcholine levels. The second wave was an NMDA antagonist or glutamate blocking drug called Memantine. And both these drugs are even combined together, again, don't change the overall progress of the disease. They were approved by the FDA because they resulted in slight slowing of the decrements cognitively and functionally that people show with Alzheimer's disease. But the third wave of medications, and those are using human monoclonal antibodies against amyloid beta, and aducanumab and lecanemab are the 2 out there right now. I'll get into that. Do seem more targeted, at least a part of the physical process by which Alzheimer's progresses. Whether it's the ultimate cause or origin is open to debate. And there is a larger clinical, not improvement, because improvement suggests people are getting better. At a group level, what we see is a reduced progression. So less over 18 months' time, over a year's time, people have deteriorated not as much on these drugs as they would in an untreated state. On the other hand, the biological impact in terms of clearing amyloid plaques from the brain seems to be much more robust with these drugs. And there are a number of companies with rival drugs working on the same mechanism. There are a number of other drugs with other mechanisms on the way. But right now, we do not have any medications that consistently at a group level reverse or improve brain functioning in people with Alzheimer's. So launching into it. So what is Alzheimer's? So it is a form of dementia. It's the commonest type of dementia, at least in countries that have been where it's been studied. So about 3/4 of dementias seem to fit in an Alzheimer's disease category, but many of these are not pure Alzheimer's. So many of these are what we call combined dementias, where either Parkinson's disease or the second most common is vascular dementia is combining with the Alzheimer's type to provide a mixed picture when we look at brain tissue, usually after death. So Alzheimer's is a progressive neurodegenerative disease, usually starting with affecting memory, language, and cognitive functioning, and continuing to progress so that even simple tasks and eventually even things like breathing and muscle control are lost. And again, people do die from this. So what we know now is that there is a preclinical phase that probably lasts at least 20 years in most people, where there are measurable changes, I would say deteriorations in different aspects of the brain, but that clinically the person is looking completely normal. After that, there is what's called mild cognitive impairment, or MCI, where someone's making maybe more forgetful errors, senior moments, losing track of things, having trouble finding words, misspeaking than someone their age might be expected to have, but they're still able to function in their role in life. And then Alzheimer's itself is broken into mild, moderate, and severe categories as it progresses, depending on the extent of symptom severity and interference with functioning and ability to live and act and take care of oneself alone. And this is a big problem. So there are currently, by best studies, at least 5 million people in the US with MCI, so mild cognitive impairment, and probably another 5 million with Alzheimer's who are clinically diagnosed with Alzheimer's. There's some debate whether it's 5, 6, 7 million in each of these two categories. So these are not precise exact numbers. And part of it is many of the people who have been diagnosed with Alzheimer's have been diagnosed clinically. So it looks like, their pattern of decrement or degradation in cognitive functioning looks like an Alzheimer's pattern, but they may not necessarily have had any anatomical brain tests to confirm or support it. So previously, to the last few years, the only definitive way of diagnosing Alzheimer's disease is to have a clinical syndrome of dementia pattern in combination with, on brain biopsy, the presence of abundant amyloid plaque and neurofibrillary tangles in parts of the brain that are involved in this process. So that can be done on a brain biopsy, so taking a brain sample from someone alive, which is something we are usually quite reluctant to do unless it's really important to do so, or on an autopsy. Now, in the last few years, and none of these have yet been approved for widespread use by the FDA, but many companies are developing both central nervous CSF, cerebrospinal fluid markers, where you have to do a spinal tap and remove some liquid, or even blood samples to measure how much amyloid beta proteins or tau fibrillary protein related markers, so how much are circulating in your body as a marker. And often, currently, those are clinically linked with doing PET scans to look at the distribution of the accumulation of beta amyloid plaques and tau fibrillary tangles within the brain. Again, that PET scans themselves have not been FDA officially sanctioned as a way to diagnose it, but widely are being used to do so. So important neurochemical parts of the process with Alzheimer's is that some of the most early neurochemical changes that were detected and extensively studied are decreases in levels of acetylcholine circulating within the brain and death or dying of acetylcholine neurons, which we know are important for memory. And this is important for the first rounds of medications we use to treat the Alzheimer's process. And again, what are considered the diagnostic or our best diagnostic markers right now for Alzheimer's are the accumulation of amyloid beta plaque. So amyloid beta precursor protein is a big protein. It's a membrane-bound protein that is found throughout the body, including in the brain. And in the brain, it's involved in important neuron growth and repair processes. So it's a normal, healthy protein that everyone has, but there are a number of different enzymes that can cleave or snip off different parts of the big protein to make smaller active and inactive molecules. And the beta protein is a polypeptide, is a smaller section of this large protein that gets cleaved off. And when it is cleaved in a certain place, it folds or bends in shapes that are essentially cause inflammatory reactions, cause accumulation of proteins glomming onto each other. So these beta amyloid fragments accumulate outside of the cells in what are called beta amyloid plaques, and they draw in more inflammation, more cell death, more disruption of synaptic connections, and eventually, again, cell death and deterioration. At the same, or the related but separate protein is a neurofibrillary, neurotubular protein called the tau protein. And disruptions of normal tau protein metabolism result in tangles or neurofibrillary tangles within brain cells. And in general, this is a gross oversimplification, but usually accumulation of beta plaques outside the cells are seen to a greater extent and earlier than the tau protein within the cells. But the tau protein damage actually tracks or correlates better with functional decrements in neurologic degeneration and cognitive function degradation. So the medications to treat this Alzheimer's, or to try to treat it, so the first ones that were developed starting almost 30 years ago, 1993, the first was a molecule called tacrine, and then shortly followed in the next few years by donepezil, rivastigmine, and galantamine. All of these are what are called acetylcholinesterase inhibitors. So acetylcholine is a neurotransmitter. It's, again, important for memory function. It's important in other functions as well. Not only is it an important neurotransmitter within the brain, it's an important neurotransmitter for muscle sending muscle contraction throughout the body. But we're going to focus on the brain. And for all our neurotransmitters, they're either taken up back into the cells, which is what reuptake inhibitors block, or there are enzymes that chew up the neurotransmitter after it's released so that it stops acting on the postsynaptic receptor. Usually both processes are going on. So acetylcholinesterase is the major enzyme for getting rid of acetylcholine. So the acetylcholinesterase inhibitors are drugs that block the enzyme that normally would be degrading or breaking down acetylcholine, allowing acetylcholine to last longer. So if you have fewer acetyl cells that are making acetylcholine and they're releasing less of it, but if you deliver these drugs, then these drugs can let you actually use a smaller amount for a longer period of time, so get more of your signal through. So these drugs, again, are not changing any part of the process, and at best they had, so they did well enough in terms of, compared to groups not on the drug, there was a somewhat slower decline in cognitive function and functional, living independently, other things that get lost as Alzheimer's progresses. But again, people were not improving their memory, were not functioning better on these drugs. They were just on a group average deteriorating less quickly. And it was a fairly small change, but given that this is a horrible disease and horrible process, people jumped at any option to even potentially slow it down. The first drug released, tacrine, had a fairly high rate of fairly serious liver damage. So tacrine was pulled from the market 20 years after it came out in 2013. The other three, the donepezil, galantamine, and blanking on the third one right now, are still there and available, and they're approved for mild, moderate, and severe stages of Alzheimer's, and they seem to, again, have some benefit for slowing progression of symptoms in all of those conditions. There's also evidence that all three of these can help with memory loss and other dementing conditions. So there's evidence that a purely vascular dementia, and again, all of these dementias also to some extent affect those acetylcholine neurons in the brain. There's evidence that they can help with Lewy body dementia, with Parkinson's-based dementia, and even with traumatic brain injury memory issues. There have been some studies of acetylcholinesterase inhibitors in ADHD, and no overwhelmingly positive results so far. There's also some evidence that some of the acetylcholinesterase or anticholinesterase drugs can decrease inflammation in the brain, which also may be beneficial. Nausea, diarrhea, vomiting, gastrointestinal effects are fairly common with these drugs. Usually those are dose related or dosage increase related, usually going lower and slower, and usually within a few days to a few weeks, those go away. People can also have insomnia, fatigue, decreased appetite, muscle cramps, and those are all dose-related side effects. And some people do have more serious slowing of heart rate and or arrhythmias of the heart. Blood pressure can either go up or down, and seizures can happen with these drugs. So that was the very first wave of Alzheimer's drugs. The second wave was a single drug called Memantine. It is not an acetylcholinesterase inhibitor. It is a glutamate blocking drug, so specifically the NMDA receptor. And in inflammatory brain conditions where glutamate is the most abundant neurotransmitter in the brain, and it is an excitatory neurotransmitter. If there's too much excitation, too many nerve cells are overactivated, that actually can lead to nerve cell death. So this slows down the rate of over-excitation and reduces, hopefully, cell death resulting from over-excitation. Memantine's effects also on Alzheimer's are roughly comparable to the acetylcholinesterase inhibitors. So again, it's not making people improving their function, it's slowing down the rate at which their functioning was decreasing. And Memantine, there's a combination pill with donepezil with one of the acetylcholinesterase inhibitors, because many people wind up taking the two together. I should mention that donepezil is also available as a skin patch for people who have trouble taking pills, particularly as Alzheimer's progresses. Swallowing can be a problem. With Memantine itself, dizziness, headaches, confusion, diarrhea, constipation are all moderately common. Usually those go away at time. Some people have more severe issues with pain, fatigue, hypertension, hallucinations, or confusion. Usually, though, it's pretty well tolerated. There are also some studies of Memantine for treating ADHD, and the effects were smaller than what we see with Ritalin, but not negligible, and it was fairly well tolerated. So that brings us to the third wave of anti-Alzheimer medications, and the two that are currently on the market are aducanumab or Aduhelm and lecanemab or Leqembi. Aducanumab was approved in 2021 under some amount of controversy. It was approved under the FDA's accelerated approval pathway for drugs because, again, the previous two waves of drugs decrease the rate of slowing. They don't seem to alter the fundamental pathology by which Alzheimer's progresses and develops, and they don't reverse the condition at all. So we clearly need more drugs that will work on the system. It was issued under conditional approval, so most of the evidence when it was approved was based on, so the monoclonal, these two drugs are human monoclonal antibodies, so they are evoking an immune response. They are identifying and attacking the amyloid beta and binding to it and clearing it from the body. And the approval for the aducanumab was largely based on measures of decreased amount of amyloid beta in the brain after treatment with this drug. So in opposition to the other drugs I've talked about, which are oral pills, these are currently IV infusion medications. The Leqembi has undergone trials where a subcutaneous injection works actually better than the IV infusion. The IV infusions with Leqembi are twice a month. I believe with aducanumab, Aduhelm, it's once a month. Don't quote me on that one. So the objections, and there were several people on the FDA panel who quit working with the FDA because of the approval. They objected because the evidence that it had a big impact on the clinical deterioration was minimal. And the other problem, other than cost, which was excessive, so when aducanumab came out, their initial price was $56,000 a year. After about a year, they cut it to $28,000. that might be why I think the latest study suggests fewer than 500 people in the country have been on, are being treated with Aduhelm out of, again, more than 5 million people who would prospectively be eligible, or maybe even 10 million. So those people felt that given its costs and given its potential risk for serious side effects and minimal clinical impact, at least available at that time, it wasn't worth it. It shouldn't have been approved. The FDA said, this is a desperate, dire situation, and anything that helps a little and has, a significant effect on what we think is involved in part of the pathway for developing Alzheimer's is worth approving. So just about a week or two ago, the makers of Aduhelm have actually said that they are going to stop making it by the end of 2024. Part of that, again, is sales were less than what they expected, and two is that the Leqembi seems to be substantially more effective on a clinical basis. And there are several other companies with monoclonal antibodies directed at amyloid beta that are about to enter the market or have done testing that looks that they would also be superior to aducanumab in both clinical, primarily clinical efficacy. So the other issue with this class of drugs is a side effect that seems to affect about a quarter of people, and that is it can cause brain edema and hemorrhage. So edema is swelling and fluid. So part of this is the process by which pulling the beta amyloid plaques out of the brain space around the brain cells. Again, that's an extracellular subject. Sometimes it lodges in the small brain blood vessels and can cause swelling there and or small bleeding. Less than 1 or about 1% of these situations of swelling and bleeding can be really serious. Yeah, most of it, the other 24% or so, go away with time, and at least in the short term, again, these are tiny bleeds, more detectable on MRI scans and other brain imaging than by symptomatically. So the question, though, is how important are we causing more damage than we are helping with in the long run? These drugs haven't been around long enough to look at long-term damage or long-term benefits, although the data so far suggests that the longer people are on them, the better they are at clearing the beta amyloid plaques, and the greater the slowing compared to non-treated controls. So at somewhere between a year and a half, there is a about 30% less decrement in cognitive functioning on the groups treated with this. Again, both groups still, as a group, are tending to deteriorate. There have been case reports of people who, at least in the short term, have reported improved functioning, but on a group level, we're comparing different rates of deterioration with the human anti-beta, amyloid beta monoclonal antibody treatment group showing less decrease over time, less decay in brain function over time. One other recent advance, at least a published study, just also came out in the last month, was, again, we're using an IV treatment to deliver something we want to target at certain brain cells. And these are big monoclonal antibodies, are big molecules. It's hard for them to penetrate the blood-brain barrier. So research previously in rodent models was replicated in humans, and this study got a fair amount of attention. They only had 3 patients in it, so 3 patients, and they were actually on aducanumab, not on lecanemab. So they're on the drug that's actually already going to be discontinued. They used a special form of ultrasound that focally directed at parts of the brain, and this ultrasound was previously shown to open up the blood-brain barrier, and that allowed greater penetration of the drug to these target areas of the brain. And in this study, they measured and they could compare left side to right side in the same individual. So there was greater clearance of beta amyloid plaques in the ultrasound treated parts of the brain than on the non-treated side of the brain that was used as a comparison. It was statistically significant. The study, again, it's only 3 people, did not show a functional improvement in individuals. So it's, again, if Alzheimer's is as simple as removing beta amyloid plaque from the brain, we'd already have really good treatments for it. Because again, lecanemab certainly does a good job of that. Some of the treatments that are in the works are targeting Tau neurofibrillary tangles within the cells. Again, that seems to be more closely correlated with damage or loss of function, There's, fights among researchers over where beta amyloid plaques or Tau fibrillar tangles are more important. There's others who are just saying either one of those are just markers of what's fundamentally going wrong or not where we should be targeting. And there's a fair amount of interest increasingly on sleep. So for years, we've known people with Alzheimer's and other dementias tend to have substantial deterioration in sleep structure, durations of sleep, ability to sustain sleep for a long period of time. And that was considered a byproduct of dementia. And increasingly, we're looking at this may well be an important causative role or push the development of it. And partly because we've learned in the last decade or so that the brain's, and I have a talk earlier on this, the brain's garbage system for clearing bad proteins and other toxins from in and around the cells happens only at nighttime, and not only at nighttime, but only when you are sleeping at nighttime. So sleeping during other times of the day doesn't seem to activate the garbage clearing system. This is particularly important to be aware of for people with ADHD who tend to have irregular sleep cycles. Next week, I'm going to be talking more about the ADHD dementia connection. So this is sort of random, and I'm going to throw it in because we're talking about drugs for treating Alzheimer's. There was also another report released just a week or two ago about finding cases of doctor causing Alzheimer's by injecting substances into people. So the thing to be clear is this was not injection of any of the medications that are used to treat Alzheimer's. These were older studies using growth hormone taken from cadavers. It was prepared in a very specific way, and it appears that in a very tiny number, but horribly good outcome for these individuals, that cadaveric human growth hormone contained some beta amyloid plaques, and that injecting those plaques over time caused a cascade of, so if you have some amyloid beta floating around outside the cells that's causing plaques, that has a cascading effect, causing more and more beta amyloid to fold inappropriately and cause more plaques and clot. So that's all I'm going to say about dementia. Medications, again, there will be more things coming up. I see there are questions, and I will try to answer them right now. So, hi, Dennis. So Dennis says, are you familiar with Dale Bredesen, MD? His groundbreaking work has defined more than 50 mechanisms that contribute to tissue degeneration and Alzheimer's. So I have one of Bredesen's books on my shelf. So Dennis says his research has demonstrated that if treated early enough, memory and cognition can be restored with the multifactorial approach. And I'll just leave it that it's encouraging. It's small numbers of people, and certainly replicating it is important. I'm not suggesting this is a factor in any of those studies, but the other things to be aware of is that there are aspects of depression. There's a form of depression called pseudodementia that can look just like or look in many respects like dementia. There's a lot of ways ADHD overlaps with dementia. We tend to call ADHD an attentional problem. We tend to call dementia a memory problem, but they're both impairing executive functions, and there's a very fine line, if no line at all, between whether you're forgetting something because you were where you placed something because you were distracted by something else, and that was actually disrupting memory, or whether that was a disruption of attention, so you didn't consolidate that memory well enough. So there can be reasons that dementia-like symptoms can improve in people. I'm not, again, saying that there isn't evidence. It's just we need more evidence. We need more controlled studies. We need it replicated in other places to know how many of Bredeson's techniques and approaches are going to be generally helpful. I mean, we do know, still outside of medications, the most consistent advice, because it has the most data, are simple lifestyle measures. So stay mentally active, and actually physically active has more extensive evidence than mentally active or socially active, but those three are the tripod. So people who are engaged in interacting with others seem to develop Alzheimer's at lower rates and at later ages, whether that's, as we were talking about in the multilingual group, so in the multilingual studies with dementia, what's been seen, and not every study absolutely conforms with this, but several seem to, is that people who have dementia, who've learned multiple languages, have more brain deterioration anatomically, more accumulation of beta plaques when they're presenting the same amount of neurologic impairment as people who are monolingual. So it suggests that there might be duplicative circuits or buffer zones. So it's not that the learning a second language isn't preventing the disease process. It's more that you have more resilience for dealing with it, and the same physical onslaught is not hurting you as much early on in the process. So I don't know if we had the same problem before. Mr. AKA 1996, it just says cribriform with the asterisk, and I'm not seeing any more to the question. So I'm not sure so the cribriform plate or process is at the base of the brain near where the olfactory nerves run from the back of your nose into your brain. So it's a sort of perforated bony structure which many nerves are penetrating into the brain. I'm not sure what the question there is. I'm not seeing any other questions come up. So next week, again, we'll be more focused on ADHD and dementia, given that there is a new study claiming a tighter connection than we could previously demonstrate, and we'll talk about the implications of that. So stay healthy, stay happy, and I will be back next Tuesday at the same time.